Okay, hello everyone. We had a technical difficulty there and we are now back. So my name's Nathan from Active Health Clinic, and I'm really proud and happy tonight to be speaking with Dr. David Cunnington. So David has over 20 years experience as a sleep physician. We're just talking how long we've been working in this field for. And he has a real passion for everything to do with sleep. And so over his journey, he has helped a lot of people with invisible illnesses, as we term it. That could be orthostatic intolerance, chronic fatigue syndrome, ME, pain, and obviously as well as other central sleep disorders such as narcolepsy and idiopathic hypersomnia. So tonight we're going to learn a lot more about this and sleep and its relationship with these invisible illnesses. So we're going to start first of all with David just presenting some fantastic information, and then we'll have some times for questions, which we've got a few in, but plenty of time for everyone else at the moment. So what I'm going to do now is to hand over to David, and he will take it from here.
Great, thanks a lot, Nathan. So I'm going to talk for about 20 minutes about sleep and some concepts around sleep, and hopefully try and give you a bit of a framework of how to think about sleep and how to approach sleep. And although the title says fatigue syndromes, really what I'm talking about goes across a whole range of chronic disorders. Now, the milieu that we exist in our society is that the media messages about sleep are about what horrible things are going to happen to us if we don't get enough sleep. And for a patient population who may already have sleep problems for biological reasons or as part of their disorders, this can really just add to difficulties with sleep, put more pressure on sleep. But one of the important things to realise is this data that shows that not getting enough sleep has negative consequences is very large-scale population data. So it's really looking at people who choose not to sleep. So, for example, societies that don't value sleep and just work, Japan, some of those other Asian cultures, the US sort of culture, and showing that societies that don't respect sleep and choose to be busy and not sleep have more health consequences. That's totally different from someone who's got a chronic disorder and sets aside time for sleep but doesn't necessarily fill that space with sleep. It's a totally different thing. So the data about the impacts of lack of sleep doesn't apply to that group. But the media is not that subtle. There's not that subtle messaging. There's just the messaging, you're not sleeping, it's going to make your medical condition worse. You're not sleeping, you're going to die, you're going to get Alzheimer's. So really you almost got to turn a deaf ear to those sort of messages. Another important concept about sleep is that sleeping well requires a healthy body and a sound and healthy mind. And so someone who's got a chronic medical illness should expect that sleep will be different. Now, it doesn't mean bad, it doesn't mean worse, it doesn't mean not working, just different. And so if I'm seeing somebody who's got a chronic illness and they're reporting that sleep is different to what they expect, sometimes it's the expectation that's the problem because of a lack of a realisation that sleep's really a barometer of and dependent on health. And if there's something else not right with health, sleep's going to be different to somebody who is healthy. Doesn't mean the problem is sleep and doesn't mean the fix to someone's chronic medical condition is making sleep back to what they expect it to be. But just think of sleep as something that needs healthy mind, healthy body to work well. All right. Now, one of the really challenging things is trying to define what's good sleep. And this is really relevant when people are trying to tell me about sleep. And I saw someone for the first time today where this came up in conversation, where we're really talking about how sleep feels to somebody. So that's one way of defining good sleep. What does it feel like? How much awareness is there? How many times were there awakenings? What time did it occur? But a totally different way of defining good sleep is what an observer might see. So what a bed partner might see, what an activity tracker, for example, might monitor. And that's different again from what's actually happening biologically. So if we measure biologically what's happening with EEG, brainwave patterns, so I'll keep going. I'll just pop the slides up. So really what I was talking about is think about good sleep that can be defined in a range of different ways. It can be defined about how it feels. So that's the person who's actually sleeping. Another way of defining it is what it looks like. So someone who's watching somebody sleep, or what an activity tracker, for example, might sense, can be defined about what's happening physiologically or biologically. And the fourth way of defining sleep is the functional outcome. So does it allow people to feel good during the day? Now that's hard in chronic and invisible illnesses because people don't feel good during the day anyway. So it's hard to judge the outcome of sleep on that variable. But you think of your own experience, there'll be lots of times when sleep might have felt a certain way to you, but looked different to somebody else. And then maybe you've had some type of testing done and it looks different again. So don't just take how sleep feels as the guarantee that that means, well, there's something not right about sleep, or I'm not getting enough deep sleep, or I'm not getting enough REM sleep, because those things aren't as tightly correlated as what we might think. It's important when we're talking about fatigue. So one of the things I try to do clinically when I'm working with people with chronic illnesses is try and tease out the language, because the language between fatigue and sleepiness and tiredness overlaps a lot. But if I try and map it then to the biology and what I'm actually trying to treat, they're often different things. Because if I look at a dictionary definition of these terms, fatigue, tiredness, sleepiness, they're different. So fatigue, that weariness from bodily or mentally exertion, tiredness, exhausted, but also covers fatigued and sleepy. And then sleepiness, need to sleep, drowsy. Really when I try and think about it in a clinical sense, I'm thinking of sleepiness as the head nods, heavy eyelids, must sleep. I'm thinking of fatigue as I'm spent, I haven't got any more energy left, I'm exhausted. Now, sleep ain't the cure for fatigue, okay? And sleep's also not the cure for, that post-exertional malaise. It's rest. So don't undervalue rest, and don't sort of see sleep as the only form of restoration. Because sometimes if people feel that, okay, sleep is the cure to my fatigue, my tiredness, my sleepiness, my everything, then they're really looking for, expecting more out of sleep than what's realistic, which in turn puts pressure on sleep. Sometimes if people feel tired in the morning, that's a reinforcer to them that there's something wrong with sleep, or that there's a sleep quality issue. In fact, it's normal for human beings to take around 2 hours to feel like they're about 80% of their optimal performance. So that's normal. So when the alarm goes, feeling like you want to push the snooze button, feeling like I don't really want to get up and it's going to take me a while to get going, is pretty much the normal human experience. We all aspire to, and we get sort of sold on, well, you should be leaping out of bed, attacking the day and the sun shining. It's only about 3% of the population have a sleep clock that does that. But the other 97% of the population aspire to be like that. So don't take that first hour of how you feel in the morning as a sign that there's something wrong. I'm not well. Really wait until you're into the day, a couple of hours, to make that judgment about how you're feeling. Trying to understand sleep in fatigue syndromes like ME/CFS. I did a project about 5 years ago looking at patients I'd been referred in my practice who had that diagnosis. Essentially, I took people who, coming into my practice, had a label of ME/CFS from the referring doctor, and then basically tried to tease out how many of those met a consensus criteria diagnosis. No worries. Thanks, Nathan. So just talk about, I looked at people coming into my practice with a label of ME/CFS a few years ago, and then looked at sleep in that population, and basically found that if you looked at people who met Canadian consensus criteria for ME/CFS, they tended to take longer to get to sleep or awake more during the night than people without ME/CFS. And in a way, looking at their sleep in terms of their sleep study and what's happening in the brain looked very similar to an insomnia pattern. And that's really shaped part of my approach in terms of how I'll manage sleep in people with chronic illness. Because when we think about people with insomnia outside of chronic illness, it's got layers to it. And one of the layers that develops over time is changed thinking and behaviour around sleep. Because once people have had trouble with sleep for more than a month or so, they start to do things differently about sleep and develop different belief structures around sleep compared to good sleepers. And you can detect that if you do questionnaires. And so when I started to look at that in people with chronic illnesses like ME/CFS, I see the same pattern, that there's a shift in the belief structure and behaviour around sleep in people who've got disturbed sleep or fatigue with ME/CFS. And so then there's some good research showing if we take an insomnia approach with some CBT type approaches, so trying to address people's thinking and behaviours around sleep and get them back to the way a good sleeper thinks and behaves around sleep, that we actually can make good inroads into people's symptoms. But my expectation is different in people with chronic illnesses because there's still a large biological component to the sleep disturbance. I'm not at all saying it's all psychological, but there's a layer that develops and we can reduce that layer to get an improvement in symptoms. So yes, over and above that, there's these biological reasons why sleep is disturbed, and I'll talk about a couple of them. But there are also these thinking styles, beliefs around sleep that if we address, we can make some inroads with a CBT type approach. When we look at what's actually been found to be abnormal in sleep with ME/CFS and chronic illnesses, there's really two main themes. And one theme is about the body clock. Now, we all have an intrinsic body clock called the circadian rhythm. And our circadian rhythm is designed to be synchronized every day and respond to external stimuli, so light, movement, and meals. And if you think about someone who's got a chronic illness or a fatigue syndrome, they get exposed to far less outdoor light than people who are healthy. They have often a more irregular routine because they may not be able to work and have the same external structure. And they also don't necessarily keep regular meal times. Not that anyone else keeps regular meal times in 2020 either. Everyone's sort of grazing and eating on the go. And so there's less inputs to the circadian system, which then essentially makes the body clock less of an up and a down, less of a wake and a sleep variation across 24 hours, and more leads to a bit of a, well, what we call a flat rhythm, so that across the day, people feel more tired than expect to be, and then at night feel less sleepy than they expect to be. Because if you think of the circadian rhythm as something that's got an up and a down, if that's got a shallower up and a shallower down, there's not as much of a waking signal through the day or as much of a sleeping signal through the night. So that's one thing to address with the circadian rhythm. The second thing that can happen is once you stop getting exposed to outdoor light and have these synchronizing cues, the body clock can drift to a later pattern. And so what that means is not getting a feeling like going to sleep until later and not a feeling like waking up. Thanks, Nathan. Okay, so then I was talking about the circadian rhythm. So people with chronic illnesses essentially get two problems. So a flatter circadian rhythm because they don't get exposed to external stimuli, and then a delayed circadian rhythm where the body clock doesn't want to go to sleep till later and don't want to wake up till later. And so the key to addressing those body clock issues is trying to get light exposure. So particularly outdoor light, but we sometimes use blue light as a way in the morning of keying in the body clock to say, right, this is the morning, this is the time to get going. But other inputs to the circadian system are important. So movement can also key in the circadian system, as can meals. So that regularity of morning light exposure, movement, and meals is really important in getting the circadian rhythm working well. And it's a tricky balance because in chronic illness or fatigue syndromes, unlike people without those disorders, I can be a bit harsher. So someone who doesn't have any other comorbidities, I can beat them up a bit and say, come on, just do it, get your act together. But in people who've got fatigue syndromes, it's a really tricky balance. Yes, you want to try to keep entraining the circadian system, but you don't want to really put people under a great amount of strain either. So it is a delicate balance to get that right. And then the second major physiological abnormality I see in people with fatigue syndromes and chronic illnesses around sleep is what we call the arousal system. So think of that as the sympathetic nervous system, or we call it monoaminergic system, but those adrenaline hormones essentially being high and not switching off in the way they should during the night. And there's a whole range of reasons for that. Sometimes there's associated orthostatic intolerance that can be a driver for that. Think of it as a physiological protective mechanism in the body. So if things aren't well in the body, then of course the body's going to be in more of a fight, flight, protective mode, which is that high adrenaline mode. And that gives rise to often the sensation of sleep being light, easily disturbed, time spent on the boundary of sleep and wake, with some of the strange experiences that can occur in that boundary between sleep and wake. And for some people, it can also give them the perception of being awake whilst they're actually asleep, and make it a bit hard to judge exactly how much sleep's occurring. That's what I was talking about a bit earlier with that. Don't mistake how sleep feels with what's actually going on during sleep, because those two things don't always relate, particularly when there's this heightened adrenaline and the impact that can have on sleep. So when I'm then trying to manage people who've got chronic illness and problems with fatigue syndromes and their sleep, so one of the first things I'm doing is, in some respects, just let them talk. I want to hear what sleep means to people, how they're approaching sleep, because sometimes it's pretty obvious. People are trying too hard. They've got too many rules around sleep. They've got this change thinking and behaviour around sleep that's actually just adding quite a lot to their sleep problems. And that I can do something about. I can chip away at that layer to help with sleep. I'm also trying to tease out those two systems. What's their circadian regulation like? So what's their timing, their routines? Are they getting that entrainment of their circadian system? And what's their arousal system like? Or where's that sympathetic nervous system sitting? Part of that is, does somebody have good strategies for reducing stress? Now, it's not that it's driven by stress, but essentially it ends up in the same place. So someone who's got a fatigue syndrome or a chronic illness needs to be a stress management ninja, in the way someone who doesn't have illness can get away with carrying stress and carrying worries without it impacting on sleep and energy levels. But people with chronic illness just can't carry it, can't get away with it in the way others can, so just have to be better at it than others do. And it's not because of, I can't deal with stress, or I don't, I'm weak. That ain't it at all. It's really just the physiologies already of a heightened adrenaline drive and heightened sympathetic nervous system activity. So there's just got to be more skills about being able to modulate that and manage that. Okay. All right. Well, they were the main points I wanted to make, Nathan. So I'm pretty happy to sort of be less formal and shoot me some questions, and we can talk through some things.
Fantastic. And again, apologies for the technical problems that we've had for everyone online tonight. But as I said, we'll cut up this video and we'll make sure that we publish it as well a little bit later. So we've had a few questions come through, and we'll also open it up to some more questions as well. As David says, the chat box, which is flashing down the bottom, please pop them in there. But we've had some questions. The first one is actually around menopause and sleep. So obviously the impact that it has upon it.
Yeah, so menopause has a couple of different impacts on sleep. So there's a shift in the baseline, if you like. So think of it as both estrogen and progesterone are somewhat protective hormones for sleep. They make sleep a bit deeper. Now, women will often be familiar with the fact that sleep's not exactly the same across a menstrual cycle. And for a lot of women, there's a part of their menstrual cycle, often in the premenstrual part of their menstrual cycle, when sleep is not quite as good and not quite as deep. And that's a bit of a window into where sleep might be without estrogen and progesterone. So as women get older and estrogen and progesterone levels decline around the perimenopause, sleep can be lighter. So just think of it as if there's a certain baseline of where sleep is, that sort of baseline just lifts a bit. It's a bit lighter, it's a bit closer to the surface, waking a bit more readily. The other part that can happen with sleep is hot flushes. So someone may be sleeping okay, but just get this sympathetic drive, sweats, high heart rate, feeling uncomfortable, feeling hot. So that's unfortunately one of the characteristics of menopause. The fortunate thing is they don't often persist long into the post-menopause. They usually settle. I do run a podcast series about sleep called Sleep Talk. There's an episode on that where I talk with an endocrinologist about menopause and ways of managing both the hormonal aspects of menopause and their impacts on sleep. And then I talk a bit about some of the sleep side. The sleep strategies are very much about cognitive strategy, so beliefs around sleep. So recognizing, you know, life's changing, hormonal levels are changing, sleep's going to change too. I shouldn't expect it's going to be just exactly the same as what it was. So that's part of the cognitive type of strategies. But in the hormonal and endocrinological sense, yeah, there is a rationale for some women for hormone replacement therapy, particularly if menopause is impacting on sleep.
Thanks, David. So I think what can you do about sleeping lighter post-menopause is probably related to that.
Right, so part of it, in some respects, just recognising sleep's going to be different. So sleep being light doesn't mean sleep is bad. That's the other thing. So just because it feels different, it feels closer to the surface, doesn't necessarily mean that, okay, I need to make it go back to feeling the way it used to feel, because it's not. And if you're going to try and make it go back to feeling the way it used to feel, you're going to have to do something to artificially make it feel like that. So take hormones, take medications. Sleep feeling different, but not translating to a different functional outcome during the day. So sleep being lighter, but still functioning okay during the day, is more about just getting used to a new normal. You know, guys as well, we've had to cope in the last 5 or 6 weeks with a new normal. That's a totally different sort of situation in terms of life, sleep, stress, you know, how our sleep patterns are different. Menopause is a bit like that. It's a new normal and just getting used to a new normal. Now, of course, there are some medications that can help, but I'm a bit loath to use medications unless someone's got the functional outcome. So if their sleep's to the point where it's impairing their daytime function, absolutely, then I'll probably look at using medications. But if it's just because it feels different, no, I'm going to really try and get people just to be a bit used to that new normal.
Great, thanks, Dave. So one of the questions is on cannabinoids. So we know that there's been a lot of talk recently in regards to that and legalization in different places and use in pain and other conditions such as nausea, etc. But what do you see its relationship is with sleep?
Yeah, so funnily enough, there is very little data on cannabinoids and sleep, very little data. And the data that's been published is very small studies of cannabinoids and their impact on sleep architecture, for example. There's just as many studies showing that it produces less REM as what there are that it produces more REM, and studies that shows it improves sleep and studies that shows it worsens sleep. It's just a total dog's breakfast in terms of the literature. The best data around sleep is sleep in conditions that have sleep disturbance as part of that condition. So there's some good data for trauma, so cannabinoids and use in trauma, where sleep disturbance is occurring as part of trauma, and the sleep improves in that situation. Severe anxiety and pain are examples of two other conditions where there is some good evidence for cannabinoids and associated sleep disturbance. There's just been a small insomnia study completed in Western Australia of a cannabinoid preparation for insomnia. So you'll sort of see that published over the next couple of months. And yes, it's the sort of biggest, you won't believe this, but it's the biggest study of insomnia and cannabinoids, and there are a total of 30 patients. That's how small the literature is. So there really is not great research. In my personal practice, absolutely, I think there's a role, and I'm very comfortable referring people on to talk to people experienced in using medicinal cannabinoids as part of an overall approach. Again, part of the podcast series, I interviewed a physician called Karen Hitchcock, who's Melbourne-based and uses cannabinoids, and I'll usually refer people to Karen if they're interested in cannabinoids because she's really knowledgeable. And it's not as if one cannabinoid's the same as another cannabinoid. It depends on what the preparation's like, what the proportions of THC and CBD and CBN. There's quite a lot to it.
And Karen's had some experience in working people with fatigue syndromes as well. So I think that is...
Yeah, absolutely. Yeah, really, really good point. You know, Karen worked at the fatigue clinic at the Alfred Hospital for a number of years.
Yes. Now, I'm sure that with this one, I'm not going to pronounce it correctly, but hypnagogic hallucinations. So someone that is part of the tribe mentioned that she has these and they can be quite traumatic, and they're basically what they're about and how they can relate to these type of illnesses, invisible illnesses.
Yeah, so certainly very distressing experience for people that get them. So there's two versions. So there's hypnagogic hallucinations. So they're visual imagery you get as you're drifting off to sleep, and then hypnopompic hallucinations that are visual imagery you get on the other end when you're coming out of sleep. And they're often associated at the same time with a thing called sleep paralysis, where people feel like they're transiently paralysed. The only muscles that can move are the muscles that move the eyeballs and the diaphragm. So people can still breathe, but that's about it. Otherwise, they feel pinned to the bed. And the description of it's very stereotypical. People feel very vulnerable, and there's often a sinister presence or someone who's going to attack them. They'll often recognise they're in their bedroom. They can see everything in their bedroom, but superimposed on that is dream imagery. So there's a hallucination or something that's not real that's superimposed on their bedroom environment. So that's what it actually, how people experience it. And imagine how distressing that is. You feel like you're totally paralysed and there's a sinister presence who's going to come and injure you and you can do absolutely nothing about it. So really distressing. So then, yeah, does it occur more in people with chronic illnesses? Yeah, absolutely, particularly when there's that heightened sympathetic nervous system activity. Because if you think of the boundary of sleep and wake a bit like a scales or a seesaw that's sort of tipping from one side to sleep and tipping to the other side to wake, if you've got a lot of sympathetic nervous system activity that's weighting down that wake side, yes, you go to sleep, but it's not going to tip the scales totally over to sleep. You're going to be stuck in this no man's land transiently in between, which is where these hallucinations and sleep paralysis occur. But they do occur in other conditions like narcolepsy. So I sometimes get referrals from GPs saying, oh, someone's got sleep paralysis, they must have narcolepsy. But no, they occur in a lot of illnesses, particularly when there's heightened sympathetic nervous system activity, like a lot of the people with chronic illness and invisible illnesses.
Thanks, David. Mary said thank you so much for what's been said so far. And Kylie's mentioned, what is the process in regards to a sleep study referrals and what's actually involved in them?
Yeah, so think of it as, well, let me split that into two. So there's a sleep study and then there's getting a sleep consultation, if you like. So for either of those, you'd need to be referred by a GP or another sort of medical practitioner. Now, going just for a sleep study has a role, but its role is really in the sleep apnea space. And it's really for someone who is a high risk of sleep apnea, pretty obvious symptoms of sleep apnea. So think of that as a heavy middle-aged guy who snores and stops breathing and then seems to gasp and choke during sleep. So that would be appropriate to just go straight and have a sleep study, and that'll tell you bad sleep apnea or not. Now, pretty much for any other clinical question, going and just having a sleep study isn't going to give you the answer that you're after. So particularly for people with chronic illness, it'll be, well, why aren't I sleeping well? Why am I fatigued during the day? Why can't I stay asleep at night? Why am I waking with sweats and these other things? Just getting referred for a sleep study won't give you any of those answers. In fact, you'll probably end up having the type of study that's not a useful study. Like someone I saw today who's got 20 years of a fatigue syndrome and lots of symptoms and got sent for a sleep apnea test, and unfortunately got sent down the rabbit hole of, well, do I need a dental appliance for my sleep apnea and other things? They haven't got sleep apnea, that was never the problem, but just got sent straight for a test. So the other referral pathway is to go and see a sleep physician first before having a test. And that involves then a clinical assessment and then trying to work out, well, what's going to be the right test for that individual? And then when I see them after a test, it's putting together the test plus the clinical side to then put together a management plan. So that's usually a better pathway to follow in people who've got complex healthcare problems. With the Direct for a Sleep study pathway, really for think you've got bad sleep apnea, want to confirm that, that's the pathway for that.
And David, so often with sleep studies, there's the overnight study, but there's also the sleep latency tests, which some people may be encouraged to do as well. Could you just tell us a little bit about that?
Yeah, so then if somebody's problem during the day is sleepiness, so less fatigue, more sleepiness, sleeping longer than the population average, and despite that still being sleepy during the day, then we'll do a test called a multiple sleep latency test, which is a way of measuring how sleepy somebody is, trying to tease out, is it sleepiness, is it tiredness, is it fatigue, and also look at how the brain goes through that process of switching off or falling asleep. Essentially, people stay in the sleep lab during the day and then every 2 hours get put back in bed, given the opportunity to have a nap, and we look at how the brain goes through that switching off process. It's a test used to diagnose narcolepsy, but often in this situation, I'm using it more, again, to think about that scales analogy of tipping from wake into sleep. If I get multiple times of that across the day, I get to see why people get stuck in that no man's land in between, or why their particular scales are unstable, why during the day they keep flicking into sleep and during the night they keep flicking into wake.
And Kathy mentioned as well, what happens if your sleep is not refreshing at all? Because we know that I'd say 99% of people that we see with fatigue or these conditions, they just wake not refreshed.
Right. So you've got to ask yourself, is it the sleep, or is it the fact that my condition is such that that fatigue is a core feature of it? That's why early on in the bit where we were a bit disturbed earlier, I was trying to talk about different ways of measuring sleep or determining whether sleep is good or bad. Now, if someone's in good health, one of the ways of working out is sleep good or bad is how do you feel during the day? Because if you feel okay during the day, probably sleep's all right. But with a chronic illness, you never feel good during the day. So it really takes that away as a measuring stick. But it's being cautious about trying to attribute the not waking up feeling good to being, well, sleep hasn't done its job. Maybe sleep actually has done its job, but there's just pervasive fatigue as part of the condition. And that's the tricky part to sort out. Is somebody going to be made better by doing something about their sleep? And that's often why I like to measure sleep, to say, okay, what sleep quality actually look like? Because it may feel not great, and the people may feel they're not functioning well during the day, but if when I look at what the brain's doing during sleep, it looks okay, then maybe we just got to, it's not the sleep that's the thing.
And one of the questions just then following on from that, David, was, can you measure brain activity outside of a sleep study?
Not really. So there's no shortage of gizmos and gadgets and increasingly more things that say they'll measure brainwave activity and a whole range of other things. You can measure stuff. The brain puts out electrical signals and you can measure stuff, but you've got to know what that actually means. So, in terms of trying to think about brainwave activity, how that relates to function, how that relates to sleep quality, we really need a sleep study to be able to do that. Now, that's different to, there are other ways of measuring sleep. So think of it as a sleep study being a very detailed but short-term sleep assessment. It's one night. Whereas I can get complementary information for a lower data intensity. Think of a Fitbit, think of a sleep diary, think of any other activity tracker over a longer term. And the two things are complementary. It's not as if one's better than the other or whatever. They actually, one's a way of measuring sleep over time, and another one's a way of measuring sleep in a short period of time, but very intensively. So there is a role for each of those. But if you want to know what the brain's doing during sleep, unfortunately, a sleep study is really the way to get it at the moment.
Fantastic. I'm just going to go through one of the questions. One of them was, how do you stop going? I think it was, how do you stop going to the toilet at night or getting up throughout the night?
I'm over 50 now. Can someone tell me the answer to that? So really, it comes back to having, again, so just some expectations and understanding about sleep. So we sleep in cycles. So people may have heard about sleep cycles. So sleep cycles anywhere between 60 minutes and 120 minutes. And part of the reason we sleep in cycles is so that we periodically come up to the surface to be able to check the environment, make sure that's safe, and then back off to sleep again. Because if you think about where we've come from, you know, you've got a tribe sleeping in a threatening environment in a cave with a woolly mammoth and whatever outside. If you've got enough members of the tribe and everyone sleeps in cycles, at any point in time, someone's going to be awake to be just keeping a lookout for the tribe. Now, you know, in our modern society, we don't have to be looking out for the threats during the night. So we want to be under the surface continuously during the night. That's actually not biologically what happens with sleep. Now, we all remember in our teenage years or early 20s in good health, we did sleep like that, just slept through like a log. But as we get older into our 30s, 40s, 50s, sleep starts to get more cyclical in nature. So that there is, yeah, thank you, there is more of this cyclical nature to sleep. So we come up to the surface more often. And when we come up to the surface, it's like, yeah, okay, there's a bit in the bladder. All right, I'll get off to the bathroom. So it's not always the having to go to the bathroom that's the cause of the awakening. It can be that there's going to be an awakening anyway, because there's cyclical awakenings during sleep. And in the same way, everything else isn't as well regulated as we get older, the bladder can get a bit twitchier. So that's the ditropan sort of story, is if the bladder's not going to hold quite as much as what it might do, because there's a little bit there and like, yeah, okay, I want to get rid of that. And so trying to stabilise that. An important thing in chronic illness too, so with it throwing out the circadian rhythm and the impact on the circadian rhythm, people with chronic illness tend to produce more urine during sleep than people who are well. So if people are well, normal circadian regulation, it shuts down urine production during sleep. People who've got chronic illness don't get that same shutting down of urine production during sleep, so have a higher urine volume. So unfortunately, I can't tell you how to stop the going to the bathroom during the night. But in some respects, seeing it as, okay, that's part of my cycle. I'm at the end of my cycle. I can reset, have a pit stop, back off to sleep. It's not ruined my sleep. It's not the thing that's going to make me tired the next day. In fact, cyclical awakenings during sleep are a normal part of sleep. I'll tell a little story as an aside. There's a really nice story from Mozambique looking at sleep in different communities, but the tribes in Mozambique get upset if people come to visit in the middle of the night, because they visit in the middle of the night with their animals and things, and don't wake them up and have tea with them. Whereas the people living a Western lifestyle in the towns in Mozambique get really annoyed if people come and wake them up during the night. And it just gives you that insight into how our expectations about being woken during the night. And waking during the night is actually not that abnormal and not something we should be trying to banish in the same way sometimes as we try to.
Fantastic. So we've got quite a few more questions and a few minutes to go. One of the questions was about what's a good circadian rhythm, or how do I get into a good circadian rhythm? I know it's a bit of a double-edged one for you, David, but good question.
So routine and external cues. That's a short story. So the external cues being outdoor light, movement, and meals, and having them as an input to the body at predictable times each day. That's the getting into a good circadian pattern.
Yeah, fantastic. And actually, getting back to the waking during the night, often we find that if people have salts closer to bed, that can help them retain fluid and make it a bit less likely, but may not necessarily last through the whole night as well.
Yeah.
So another question was, a parent says that and this can happen to a lot of us, that they could be woken in the first hour of going to sleep and then find it very hard to get back to sleep, and why that's the case.
Yeah, so it's not a natural awakening. So if the kids wake us up or other things wake us up not at the end of a cycle, particularly after the first hour or so, when it takes a while to get going, often the brain's really sort of then into a deeper sleep, takes a while to orient. So you're really trying to turn up that adrenaline drive to get yourself back up to the surface. And once you've cranked up that adrenaline drive, you can't switch it off quickly. You've got to allow enough time for that to dissipate. Now that's different towards the second half of the night when we're sleeping a bit more lightly. We don't have as much sleep debt. things will wake us more readily. But once we're woken, we can then switch it off again more readily because we haven't had to try so hard to come up to the surface.
Great. The next question I've forgotten, so I'm just going to go to it. What's going on when you feel dead tired but can't fall asleep?
Right, so then that's really tricky. So it's trying to, particularly with fatigue syndrome, it's trying to tease out, am I spent? You know, is it that my day's done, I've spent all my energy molecules or, you know, used all my spoons, you know, whatever your terminology is, but I'm actually not ready for sleep. And so I'm done, I'm cooked, there's nothing left in the tank, it's time for me to rest. But that doesn't necessarily mean it's time for you to sleep, because they are two separate things. Have you used all that physical energy versus is your brain and body ready for sleeping? The other part that comes into it, which is the psychology sort of interaction, is the more tired somebody is, the more they wish for sleep, the more elusive it's going to be. You know, the more you want it to come, the harder it's going to be. So that's, in some respects, just, yeah, I'm exhausted, I feel like I'm spent, right, permission to put my feet up, the day's done, but not necessarily going to bed until there's that heavy eyelids feeling like it, I'm sleepy.
Great. Now, I think we've got one final question from Kylie. So how do we know the difference between being sleep deprived or whether our fatigue is heightened from being in a flare with the ME/CFS?
Yeah, good question, Kylie. That's part of the challenge, is trying to tease that out. A sort of rough and ready measure is what I talked about, is how much is heavy eyelids uncontrollably falling asleep versus how much is I'm cooked, I'm spent, but I took myself to bed and I didn't go to sleep. So that's, if you didn't go to sleep when you went to bed, it's probably not that you're sleep deprived, it's probably more that fatigue, exhaustion. It'd be much better if we had a biomarker. Think of that as some sort of measure we could do. You know, you do a little dipstick and you go, yep, I'm sleepy versus fatigue. Unfortunately, we haven't got that. And if we're doing CBT in people without fatigue syndromes, the way we tease this out is as part of our insomnia treatment, we deliberately sleep deprive people, and people who, you know, come back after being deliberately sleep deprived for a week go, oh, now I know what sleepy feels like. I now recognise my cue to go to bed was I was tired, but you've really made me feel sleepy now. And so sometimes, no, I don't do it with people with fatigue syndromes because I don't want to trigger a whole lot of other flares or relapses and things. But sometimes, you know, it's trying to just recognise what that difference between fatigue and sleepiness.
Right. Fantastic, David. That's been really enlightening, and I hope for everyone that's been enlightening as well.